Well, thank you for those of you who can stay for the last 20 minutes on a beautiful day that we finally had here at the ASCO meeting. I am going to be talking about, as Kim said, the metabolic and skeletal complications of ADT. I'm first going to briefly acknowledge some of the side effects of ADT, and in my talk, I am going to be focusing on patients who do not have metastatic prostate cancer, but those with non-metastatic disease and the implications for the metabolic, cardiovascular, and skeletal complications. I'm going to throw out some suggested evaluations that you should consider before and after starting ADT, and then summarize with some take-home messages. So you may have seen this before. I show this commonly, but need to update this. But this is really the sort of laundry list of side effects of ADT from the patient's perspective. And today, really, I'm going to be focusing more on this side of this of these symptoms instead of on the left. So we know a lot about hypogonadal men and some of their risks. And hypogonadism in men that are not receiving androgen deprivation is defined by a testosterone level under 325 nanograms per deciliter. And this is a condition that clearly evolves over years in a man's life. And we know that hypogonadism is associated with the so-called metabolic syndrome, which consists of insulin resistance and/or diabetes, obesity, lipid abnormalities, and hypertension. And we also know that hypogonadal men do have an increased risk for cardiovascular death and increased all-cause mortality. On the other hand, men treated with androgen deprivation have truly extremely low levels of testosterone that occur over hours to days, depending on how you do it. And they do develop metabolic abnormalities, although they do not develop the classical metabolic syndrome seen in hypogonadal men. They do develop insulin resistance, and it can be seen quite early as 3 months. They do have weight problems. They do have lipid problems, although the only consistent finding is an increase in triglycerides. But so far, anyway, hypertension has not been blamed on ADT. The cardiovascular death, I'm going to spend a little bit more time discussing this, but the best thing to say for this quick answer is it depends. And I think that there is good data that I'll show you that there is an increase in all-cause mortality for specific men who have cardiovascular risk factors. So, you know, I'm considering cardiovascular disease under the umbrella of metabolic problems. And so what is the real cardiovascular risk of ADT? Well, in 2010, a group of subspecialty groups got together in an advisory panel and concluded that it is plausible that ADT could increase cardiovascular risk. So they went way out on a limb and told us what the answer was. That prompted later that year the FDA to request addition of safety information for GnRH analog labels to take into account the increased risk of diabetes, heart attack, sudden death, and stroke. More recent data, however, actually published by my colleague to the left, Dr. Nguyen, looked at 8 trials and did a meta-analysis in men with non-metastatic disease who were treated with radiation therapy with or without ADT, and found that cardiovascular death was not increased in those men treated with ADT compared to those who were not treated with ADT. He subsequently looked in another study at all-cause mortality and found that ADT can increase all-cause mortality in those men with known cardiovascular disease, specifically with a history of myocardial infarction or congestive heart failure. So what about different forms of ADT? Does that make a difference in terms of cardiovascular risk? And I would say that this area is still evolving, and I just want to point out a series of data that has come up over time, starting with the report by Dr. Keating in 2006 that was a very large observational, retrospective, of course, study looking at men treated with orchiectomy versus GnRH agonists. And in that study, she found that there was an increased cardiovascular risk in those treated with the agonist. Subsequently, as the antagonists became available, Matthew Smith published a prospective study looking at 2 doses of the antagonist versus agonist. And in that study, they didn't really look at risk of death. They really looked at things like ischemic changes, arrhythmias, changes on EKG, and they didn't find any differences in those treated with agonists versus antagonists. And subsequently, Dr. Smith pooled 9 trials looking at the antagonist and found that the cardiovascular events before or after starting treatment with an antagonist were no different. But during the last year, there's been new data presented both at the EAU and earlier this year at ASCO GU, looking at 6 trials and pooled data of over 2,300 patients, comparing the antagonist with the agonist, and interestingly, the risk of cardiovascular events or death was no different in men if they did not have any baseline cardiovascular disease, but it was definitely higher in men treated with the agonist versus the antagonist in those who did have baseline cardiovascular disease, and those treated with an antagonist had a relative risk reduction of 50%. Now, in the next few slides, I'm just going to show you the data that was presented in these presentations at these meetings. The data isn't published yet. So this is looking at the risk of cardiovascular event or death in all patients treated with the antagonist, degarelix, versus an LHRH or GnRH agonist. And when you look at men who had no baseline cardiovascular disease, these curves are virtually superimposable. I can't get a laser in there, Kim. But if you look at men who had baseline cardiovascular disease, there's clearly a difference in the risk of serious cardiovascular events or death. So I think that the bottom line on this is that patients who have pre-existing cardiovascular disease are at increased risk for cardiovascular events when treated with ADT, and perhaps GnRH antagonists may be associated with less risk than the agonists. However, I would say that this requires prospective evaluation. It makes sense, however, to advise our patients to follow lifestyle interventions to reduce cardiovascular risk. I'm going to turn to bone now. All humans lose bone mineral density as they age. Men lose about 0.5% per year. But you can see here that men who are treated with androgen deprivation therapy lose up to 4.6% per year, which is even greater than menopausal women. So how does ADT affect bone health? Certainly I mentioned the loss of bone mineral density that can be quite rapid in the first year, almost a little bit slower thereafter, but this leads clearly to increased risk of fracture, which has been shown previously. But the other thing that we frequently don't consider is the concomitant loss of muscle mass and strength, and this can lead to an increased risk of fall in somebody who already has fragile bones, and an increased risk of fracture. Now, men, whether they have ADT or not, are at risk for osteoporosis. And so you'll be learning a little bit of internal medicine in this, but the most common causes of osteoporosis in men are, the natural hypogonadism, or the ones that we throw them into with ADT, alcoholism, and corticosteroid use. And fractures in men are a significant cause for problems with morbidity and mortality. If you look at hip fracture in particular, there's decreased life expectancy depending on what decade you're in. And certainly men, compared to women, also have been shown to be less likely to return to independent living compared to women with hip fracture. Vertebral fractures, which we often don't think about as much, but the prevalence is quite high. It can lead to kyphosis, respiratory problems, etc., and also can impact mortality. Now, sometimes this bone health business is very confusing. At least one of my good friends in this field wanted me to make sure to emphasize this because she even finds this very confusing. So I want to point out that there is a difference between talking about bone health in patients with non-metastatic disease and skeletal-related events in patients with metastatic disease, because the approach is very different, and I think that is where the confusion comes in. So in non-metastatic disease, what we're trying to do is identify men at risk for fracture and then preventing fracture and the subsequent morbidity and mortality. And I'll talk about this workup in a moment. And then the variety of potential agents to treat patients who are in need of pharmacologic therapy. There's a whole host of options listed here. Only 2 of them, however, have been shown to reduce fracture risk. The others increase bone mineral density, but they have not been shown anyway to reduce fracture. Whereas in patients with metastatic disease, there's basically 2 options, and in this situation, DEXA scans are not necessary because we're going to be treating them for skeletal-related event issues anyway. So it's obvious that, you know, this is the kind of internal medicine history you want, but I'm just showing this laundry list to emphasize the importance of gaining this information from the patients so that you can adequately counsel them on the risks that they may incur by proceeding with ADT therapy, particularly when, you know, we're using less and less in patients with biochemical relapse. Physical exam, again, I'm emphasizing the weight here because one of the things that you should do is really follow the weight from visit to visit in your patients treated with ADT, because you will find that their weight, you know, continues to go up unless you spend a lot of time counseling them at the outset. So certainly I think spending a lot of time talking about exercise and diet is very important. Fasting glucose is a very important thing to get before you start ADT and over time as you treat them with ADT, fasting lipid panel, EKG, and vitamin D levels, and I'll talk about that in a moment. Now, there is an algorithm for how to do glucose monitoring for patients starting and continuing on ADT. And this is an older algorithm, and I think really, in fact, data from this meeting, as well as recently, might prompt you to consider the possibility of starting metformin for these patients who fall in this gray zone where they don't really meet the criteria for diabetes, but they're clearly already out of the box glucose intolerant. Now, DEXA scans, as you all know, measure bone density at the lumbar spine and the hip. This is how we diagnose either osteoporosis or osteopenia via the T-score. And this study is actually recommended by the National Osteoporosis Foundation for all men age 70 as a baseline, and for any men of any age with risk factors. And in this case, in this talk, we're talking about the risk factor of treating someone with androgen deprivation therapy. But having said that this is a recommended study by the National Osteoporosis Foundation, it is recognized that the sensitivity for predicting fracture with a DEXA scan is somewhat low, so that a patient who does not have osteoporosis can still be at risk for fracture. So how do we estimate that fracture risk? Well, we can do it now very easily with something called the FRAX. And this is something that you can download onto your smartphone or you can access on the internet. The reference is here. What this will do is a nomogram that will estimate the 10-year probability of fracture to the hip or a major osteoporotic fracture. You need to fill in the patient's age, sex, weight, height. You can answer these questions. You know, some of them you'll know, some of them you may not know. The most important thing is that in question 10, secondary osteoporosis, you want to answer yes if they're about to or they're on ADT. And you do not need the BMD results. You can just press calculate, and it will give you that patient's risk for either hip or major osteoporotic fracture. So really where I think we're the most stuck is when if a patient has normal BMD, that's one thing. If a patient has osteoporosis, that's another thing. But if the patient is in this gray zone of so-called osteopenia, where the T-score is between -1 and -2.5, if you use the FRAX and there is a greater than 3% risk for hip fracture or 20% risk of major osteoporotic fracture, that's where the NOF is suggesting that men be considered for drug therapy. Now, what about calcium and vitamin D? Well, you know, before February, I would have said, well, it's a no-brainer. You know, you want your patients to be on calcium and vitamin D. But every time you think you know everything, the U.S. Preventive Task Force comes out with something else. So this has been very confusing to patients. A lot of my patients have brought this to my attention. They recommended against calcium and vitamin D in men and certain other populations of women because of risk for renal stones. But a lot of the specialty groups have responded to this recommendation by emphasizing the importance of both calcium and vitamin D for bone health, but acknowledging that actually food should be the best source for calcium and only supplement if needed. They also point out that the major source of vitamin D is from sunlight, not from food. So sometimes it's best to measure the vitamin D level and supplement as needed. So the current recommendations are for calcium by age greater than or less than 70, 1,000 milligrams per day or 1,200 milligrams per day, depending on your age, and that this should be the total amount gained from either food or additional supplements if needed. For vitamin D, the age cutoffs are 50, and people should be getting at least 400 to 800 international units of vitamin D or higher for over 50. Now, because food sources of vitamin D are limited mainly to fatty fish and fortified products such as cereals, supplementation may be necessary, and this is why vitamin D levels are recommended. And in fact, some people need more vitamin D. For example, well, I hope you don't mind if I mention this, Dr. Nguyen, but he works in a basement. He told me today that his vitamin D level is 10. So the safe upper limit for supplementation is up to 4,000 international units daily for most adults. So how can we estimate these things? Well, I mean, I do it the easy way. I send them to my nutritionist to get a good dietary history and other information based on vitamin D. There's also lots of internet resources. There's an app in which you can estimate your daily vitamin D intake. So, you know, it's a lot of stuff to think about, but I think the take-home message is that it's very important to weigh the risks and benefits of ADT in men with non-metastatic disease in this day and age. We see that ADT can exacerbate underlying conditions in men with pre-existing metabolic or cardiovascular disease, or I should have also said underlying osteoporosis or osteopenia. And one of the things, although we know that these risks exist, there have not been good large intervention styles determining the impact of things like diet and exercise, perhaps metformin, or many of the other things that you could possibly think of that might make a difference. But we should really be emphasizing healthy lifestyles, including exercise and good diets, just for overall health until we know the results of some intervention trials. And with that, I will thank you for hanging out on a beautiful afternoon.